I have a lot of questions. So I'm not really sure which one. I guess here's where I'll come from. So Pickens County is a funder, right? We have the Healthy Community Fund. We fund a lot of agencies in this room. And I just read all the grants this weekend. So, what I'm seeing is that integrated health, care navigation, care management, case management is a theme in almost every agency. So my question is kind of, I guess, twofold. One is there a tipping point where customized care for every individual is too much for us? And then if it isn't a tipping point, how do we consolidate this care so everyone doesn't have to be a care navigator? Is that a fair question? Okay, that's one of the questions.
I know, I'm trying to think of how to respond.
Yes. I think that and we've been dealing with this for a long time, but what we need to be looking at is, one, not confusing people with too much duplication, as you're saying, where everybody has 6 or 7 case managers, and the government is kind of moving in this direction where they're trying to get one care coordinating organization, and it should probably be who the primary or what the primary need of that individual or family is, and then allow those coordinators behind the scenes to talk to each other, which and again, our closest relationship has been with MindSpring over the years, but we both have people that are called case managers, but I think we have somebody takes the lead. And we heard multiple times about Rocky Mountain Health Plans, and they are taking, in my opinion, a real leadership role in resolving the issue that you asked about. Man, I have been incredibly impressed with their openness. I originally thought, this is the evil empire. They're a health insurance company, and those of us who have to spend huge sums of money to buy health insurance for our employees don't like health insurance companies. But Rocky's quite different, and I think that's the direction we're moving in, is to have a primary coordinating entity. And all of us need to let go of some turf when that happens, and say, hey, somebody else is the best entity to be the lead on this case, and we'll fill a support need.
Yeah, I agree with Bruce on that, and I think that's something that we've been working with Mountain Family on. They have our community health workers. They also have a care coordination team of their own clients, and sometimes those folks overlap, and so we're really talking about, when we have overlapping folks, how do we, amongst the care coordinators, say, who is the lead here? Who's really the one orchestrating what's happening? And I think that's going to be important, is that we have that one lead. In the healthcare world, they're also looking at, you've probably heard the term medical home. And again, that's the idea that there is a medical entity, a healthcare entity that is your primary, that is helping sort of drive your healthcare. In terms of the other question, Nan, I really don't know how to answer the question about individualized services, and I'm not really sure how to answer that. I think there's always a tipping point. I think part of this movement, though, the way I see it, is if we can get people in sooner to more lower levels of care to meet people's needs before it becomes crisis, whether it's medical or psychiatric, I think that we will be moving towards a healthier population and maybe needing less of those individual services, or at least for a shorter period of time. That's my hope with healthcare reform and where we're headed.
I agree. Okay, does Nan keep going, or do we have? Come on up. Nan will come.
I actually have 2 questions. The first one's around, Renee did this a bit, but can you each reflect on your organization's experience with clients of limited English proficiency?
I'm sorry, I guess I didn't hear.
You already did reflect on that some. I'd love to hear you
You're off the hook,
speak
Renee.
more.
Thank you.
Okay, I heard my
Others did not reflect on that.
I would say for what public health is doing in terms of the care coordination network, because we're trying to recognize that spectrum that some individuals are working on that promotora or neighborhood navigator level, that we've made it an effort that all of our meetings are in Spanish and English, and that we have interpretation services going on at the same time, and the slides are in Spanish. And I think, as Renee said, a lot of times organizations only hire, one person of the target population, because usually that's all the organization has capacity to do. So really it's our hope that we're bringing these people into the same room to find strength in numbers and to really be able to relate and grow their experience and grow their relationships through that.
We've had some challenges with the adult population. We had an opportunity a couple of years ago to be one of the sites for a pilot project in the state on a school to work program. And it ended up failing because when a person turns 21, they have to be documented in order to receive Medicaid services. And the schools in the area, most of the kids coming out, and I think it's a real tragedy, at that time weren't documented. They were born elsewhere. And I unfortunately don't even know what happened to them. They fell off, the conveyor. But now what we're finding, and strategically we're working on this, is the immigrant population in the Valley has been here long enough that now we're starting to see lots of people who may not be English speaking that are eligible for services and are needing to revise our delivery models for that. We have several bicultural, bilingual people on our staff. With regards back to, we're talking about adults, but with our early childhood population, 40% of the kids we serve are non-English speaking families. And it's put a bit of a strain on resources because, again, there's no funding for that. Our state funding does not pay for interpreters or translators and things, but in order to meet the needs, it's something that has to be done. And I think it's something that our local communities, it's one of the places that we use our local funds to augment services to be able to hire those people, which we couldn't do if we only had state funding. But I see the need really, really expanding, particularly, as I said, in the last couple of years, because now we're suddenly getting kids who were born in the United States, who are adults, who are entitled the same as anybody else to the supports that any of our nonprofit or governmental entities have available. And that's a good thing, finally.
Mind Springs, we, I can echo a lot of what Bruce said. We certainly serve quite a few folks with limited English proficiency. We work to get all of our written information out in both Spanish and English. We are working on translating our website to be Spanish as well. In terms of direct service, I would hire as many bilingual people as I could find. It's difficult when you're talking about a therapist. You need somebody who not only has Spanish and English proficiency, but also that specific education background to be a therapist or a psychiatrist. That said, I know we were just interviewing a Spanish-speaking psychiatrist as potentially could do some services for the company. We do have in Glenwood and Aspen people who answer the phones, who can answer the phones in Spanish. We have Spanish-speaking case managers. And one of those I am training. You gotta raise them from the ground up to be a therapist. So, every opportunity we're really trying to find ways of serving this community as best as we can. And we do use interpreters, and in the Glenwood office, we actually have a full-time interpreter who is available for our other sites. We also have a relief interpreter in Rifle. Both of those folks have done some credentialed classes on healthcare interpreting, because it's also a value of mine and of Mind Springs that we don't just bring in somebody and say, hey, awesome, you speak Spanish, come on in and interpret. It's a real skill to interpret. And so we're really trying to look at making sure that if we have to use interpreting, that we do it at a quality professional level for the people that we serve.
So my other question is just a broad question, since this is a panel on adult support services. If anyone wants to reflect on kind of what they see as the key needs for the adult population in this valley, or the key challenges for the adult population in the valley.
Well, I will say one thing that just pops into my mind, because I'm already working on maybe bringing in some training, as well as it's something Mind Springs is looking at. It's a little beyond the traditional adult, but we are seeing an aging population, and the geriatric needs, the older adult needs, are just growing by leaps and bounds. I know adult protection struggles with this. I was just talking to our county attorney about some of these changes, and I just think that's an area of how do we address our current older adult population, and how do we start to build infrastructure as our population continues to age, because I just see that as an area we need some more expertise and probably some systematic community thinking about how we address that.
I think that the biggest issue, I agree with Jackie, and I mentioned it earlier, the aging population is something that we have to, and again, we deal with a very small subset of the world of human services, but the aging population is posing challenges that we didn't realize in the past. To me, the biggest barrier that our entity faces is we have staff that are committed to bettering the lives of the people that we support, and they want to spend their time doing that. And it's particularly true with case managers. And the bureaucracy has become almost unbearable in the last few years. Medicaid is a nightmare if you're dependent on it, which we're very dependent on it. Our case managers would rather be problem solving with people and other entities, but the only way they get funding is by sitting in front of a computer and entering 15-minute intervals of contacts. And that's nuts, and I think that's, we're talking about healthcare reform. We also need to be talking to the folks in Baltimore about CMS looking at some changes and allowing the resources that are sent to our communities to actually be used for providing services and not filling out forms or entering data in computers, because they've gone so overboard on what they consider to be accountability that for years, case managers were the most happy and consistent employees that we had, and our turnover in the last 5 years since the Medicaid went to the 15-minute intervals has been phenomenal. I mean, people burn out in a year. They don't want to do it. They want to work with people, and I don't know what we as a community can do about that. I've talked to our U.S. representatives and senators, and they're sympathetic, but nothing happens.
Yeah. If I understood the question correctly, I think for responses population, the challenge is where there was a shift in the domestic violence movement and the sexual assault movement for things to be client-centered. Years and years ago, the victim came to the agency and we had a comprehensive program, counseling, group counseling, education. We were fixing her. And quite honestly, what we heard is that they don't need to be fixed. So we took a more client-centered approach. And what happens is that that looks different for everybody, or differently for everybody. There may be, in the people in the underserved community, we're seeing that the services needed are a little more extensive or beyond what we normally would do. But again, part of that problem, excuse me, facilitated or was used as an excuse to facilitate the abuse. So we're seeing for the adult population that it's one person to work with a family can be more time consuming than for other individuals. And how we're addressing that is taking a look at it and studying it. Can't really say that we have a resolution for the problem yet.
I think just from a public health perspective in that area, everyone knows this, it's kind of the lack of providers that accept Medicaid or new Medicaid and specialists in the region. So as we are getting an aging adult population and as that's growing, it's just, we're gonna need more providers here. We're gonna, need to do something to keep people here, and it's kind of a big burden, and I have no solutions. None.
I just had a quick corollary for you, Renee. Earlier in your presentation, you mentioned that you see mostly the populations up to 55. And that made me wonder, what about the women, mostly women, after 55? I'm wondering where they are in the population or...
Right. There definitely are, I would have to say, if given the statistics, there are probably more victims over that age group than what we're seeing. Excuse me. And so I think that's part of our outreach, part of when we do our marketing, part of our marketing piece is to reach out to the older women. Now, we have seen people in the age group, but not a lot compared to the numbers in the community. So, yeah.
Other questions? Amber, come on. Oh, Amy first, and then, okay, Amy, then Lindsay, we will proceed. Very good.
Thank you, Bruce, for bringing up Medicaid. I sat on, I can't vote, but I sat on the United Way Committee for Grants and kind of just led them along. And then I also was on the Garfield County Committee, and I don't know if Nan went through this or not, but the comments were almost similar that were coming out. So I guess part of mine is a statement and part of mine is a question for you all. One of the statements coming out was, oh, that's a duplication of services. I heard that over and over and over. I don't know how we get beyond that. So that would be if you want to address that one. The other one is we noticed a difference in the financials because, of course, there's now more Medicaid money because of the Affordable Care Act. And people said, oh, look at all the money they have. I go, no. So we kind of went through the whole bottom line thing with Medicaid money that kind of skewed the data slightly. And the third comment that kept coming out is, no, our tax dollars should be covering that. Those groups are within, whether it was education or whatever, they're already getting a ton of money. So those were the things that just kept coming up in both groups that were separate with no overlap. So that's a long question. You can answer or address any piece of that if you would.
So let me just rephrase. So in your reviewing of the grant applications, those were the comments from the review team about the grants?
The two totally separate review teams that really had nothing to do with each other per se.
Okay. So non-duplication, sorry.
I know, I'm trying to, Amy, that was a really long thing. Is there a way to summarize
services,
this?
for example, and I hope Laura doesn't mind me saying it, it's like, oh, English in action is the same as literacy outreach. I go, no, different population, different geographically. The Medicaid monies, which some of you probably have and some don't, about, wow, look at all that extra money they got from the government. So I figured Bruce would love to answer that one.
I will.
Yeah,
Sure.
And then the other one was, no, we're already giving money to that. Our tax dollars go to huge programs there
Okay.
which don't cover you as much as other people in the audience, by the way. So, does that make sense?
Okay. All right. Thank you. Do you want to start?
I love Medicaid. The reason, and I think this is across the scale for all of us, no matter what population we serve. I've done a really valid analysis of cost of providing services across the state of Colorado in my field. And the range, okay, first off, Medicaid funding for most of us is the same whether you're in La Junta or you're in Aspen. But it costs a different amount of money to provide the same service. So in the 20 entities like Mountain Valley across the state, the range is of the state average is 85% to 124% of the state average. And that's a weighted average based on the school district cost of living data for each of, in my case, the 4 counties we serve. We're at the 124% range. So the folks at the 85% have essentially 40% more dollars to do the same job. And that's why the local funds are so important. We can't, based on the funding that we get, and our organization gets about $8.5 million of Medicaid funding a year. Mm-hmm. Well, first off, we carry about $300,000 of that as a receivable that we're financing the state of Colorado's operations, because the only time we'll ever see that is if we close down and it comes in 60 days later. But we cannot meet the needs of our population with those funds because they only cover a portion of the actual cost of doing business. And in my world, I've been working, the state's submitting new Medicaid waivers, trying to get geographic modifiers, and having very little luck because, again, in our 20, and I only know about our service delivery system, but again, I think it's going to fit across the board. There are only 3 programs in the state of Colorado that are over 102% of the average. It's us, Steamboat Springs, and Boulder. So politically, Steamboat Springs, us, and Boulder don't have enough votes in the legislature to make something happen. So therefore, the local money, the United Way, particularly the counties, Pitkin County is extremely generous and appreciated, are what help to fill that gap. And we couldn't do it without those things. So, even though some of us look like we have lots of money coming in, we have huge amounts of money going out.
Yeah. And I would echo what Bruce said. It certainly has improved the ability to provide services and increase staffing, but it has not met all of the gaps, and Medicaid doesn't pay for every need in the community. The other thing, from a behavioral health perspective, is there are folks in our communities that is very important that we serve who do not qualify for Medicaid. And there are also folks in our communities who don't qualify for Medicaid because they work and they make too much money and they haven't yet maybe bought into the healthcare plan, or they are underinsured. They have healthcare, but they can't afford to use it. The deductible's too big. And when we receive community funding, it allows us to help those people as well, because those people aren't covered by Medicaid, and it allows us to be able to have some flexibility in helping some of those working folks who don't have access to health care, or some of the other folks in our community who don't have access to Medicaid.
I guess I can speak to the non-duplication of services, because that's a hot button of mine. But I think with the grant applications in, I don't know if they're saying they're not going to duplicate services or kind of what the situation is there, but I think as a community getting to, I know we get together a lot, but I think in some way trying to have an efficient method of being up to date on who's doing what and for who and in what area is really important because we do have a lot of overlapping services and people that are working really hard to accomplish some things and not others, and others overlapping, and everyone, I truly believe, is doing it from a great place in their heart, really trying to serve our community, but figuring out whether it's 211 or whatever we're gonna do to really start streamlining our efforts and getting a communication system in place so that we are all aware of what's going on and who to access for what services. So,
If I could just speak to duplication, I think it's really important that the panel members or those that are reviewing it take a look at transportation issues, people wanting to remain in their community, the cost to leave their community. And I don't know if those variables were part of the duplication that you mentioned, but for example, we had a client who needed services several nights ago, and all the hotels in Aspen-Picken County were full. So we reached out to a hotel in Glenwood Springs, and the patient or the client's response was, "That's really far." So I don't remember the complexities of her case. I don't know if she had her own transportation. But when one looks at having to leave their community to seek services, I think that's a barrier. So that may be part of the duplication you're seeing. I'm not sure if it is, but I do know when we talk in terms of geograph and clients accessing the services based on where we're located and where they're located, it presents a problem. We're even starting to look at how we can purchase bus vouchers and make those available to people so that they can get where they need to receive the services.
Jackie, I just wanted to follow up. Is the individual who's in the Basalt in the Mountain Family Health Center, do they speak Spanish?
They do not speak Spanish.
So do they work with somebody who can translate, if that is it?
I believe so, yes.
And then would they also see patients who are children if needed?
Yes,
In
they
that
can.
setting?
Yes,
Okay, great.
in all of our Mountain Family settings, they could see children and families, yes.
My questions are much more specific than broad. And
Oh, good.
my other question for you, Jackie, is when you have somebody, the behavior specialist who's seeing the clients who are chronically going to the ER, how many individuals can that person work with at a given time? Like, what is the capacity there, and how much need is there?
Right. I think their capacity is somewhere around 15 people at a time. I mean, again, I think the idea is we get somebody stable working their program, and then they don't need that community health worker anymore, and they take a new person. I don't think this is meant to be a lifelong journey with folks, but I think 15 to 20 people is what Rocky's looking at with that.
I'm just curious, is that how many there? Like, does that fill that need, or are there hundreds of people who chronically use the ER? I just don't have a gauge on that.
I think for the very narrow definition that Rocky's put on this position, that's probably okay. Is there a role for more people to be doing that in the healthcare world? I think absolutely, but that gets back to insurance and funding, and right now, insurances, there isn't a way to bill that. And by the way, one of our community health workers she's in Garfield, but she will also take some Spanish-speaking Pitkin folks, is Spanish-speaking, just to say that.
Okay, great. And then Jess, I wanted to ask you, who are the care navigators that you guys are working with? I don't need names, I'm just curious what organizations they're with and how you've identified them.
sure. So we did kind of a very broad reach this time, which worked to our benefit and also not to our benefit in a couple ways. But so we left it broad. We didn't want to say your job title has to be community health worker or patient navigator. We really looked at, we said, you know, if you're working one-on-one with individuals to improve their health outcomes, then this is for you. That being said, we got a couple people that said, but I already go to the Mid-Valley meetings and I go to the POD meetings. This is a total duplication. And I would say then it's not for those people. It's really for the individuals we had individuals from Valley Settlement, from Advocate Safe House, from Rocky Mountain Health Plans, from Mind Springs, from trying to think, from the public health agencies, from human services, from like going through from Family Visitor, we had Valley View, we had Mid-Valley Family Practice there. So there was quite a broad range. I think in the future, we might look at separating it out for individuals that are working maybe with more on that community resource level that are doing, more referrals to, you know, income assistance or referrals just to community-based resources versus individuals that are working within a medical setting and might need to know more about Medicare and Medicaid and those, I want to say, higher level medical intricacies. So we're definitely still in the planning process and refining process to see, does it make sense to separate these two populations out and then maybe bring them together for resource sharing or kind of what that would look like. So it's still, I'm open to suggestions.
Hi. Well, I have a concern, and first I want to share something. I worked before like a family advocate, and something I always do with the families is trying to run and catch all the service and try to feed this family to the service. And was really hard because some of the families, you have a lot of the service have a lot of requirements, and something really big is not only the language or the transportation, it's about the legal status. And every time they have a problem, we try to run around and try to find all the resources. But later we have this big no because they're not legal. Because they're not legal, you can have all these huge opportunities to do it something. I have one case was a lady that she has a really bad depression. I try and encourage to go to Mind Springs, but she don't want to do it because she was afraid to do it. She was not legal. Her language, and we say, you know, for the language, we think we cover it. Mind Springs is gonna do something, but she was not feeling comfortable because she was not legal. So we find a pastor in one of the church, and the pastor helped. But I think she still need help. She still need meds. You need more, like, to see a doctor, you know. So that's something that I really want to share. Is I don't know how it works with you guys or with everybody about legal status, but that's something is huge that closed the door for a lot of families.
Well, and I know that that's a real concern for a lot of folks in the Valley. I do want to say really clearly that we do not report people to immigration. We do not share that information at all. People can come to Mind Springs and get services whether they are documented or not. And, you know, part of my hope with having, I would love to get a peer specialist who's Spanish speaking someday to be able to help do some of that engagement. That's one of my dreams up there on the list. But, you know, my hope also is if this person would even go to Mountain Family, go to the primary care doctor, meet with Sarah out there, and maybe again kind of gradually come into our system. How do we get people feeling comfortable? Because we truly are not a threat related to them being deported, but I know that's a real fear. And so, you know, I think we need some help in bridging the fear and the reality is we're going to serve people without consequences who come to our door.
For us at Response, we don't disclose the person's status. And so right now with that marketing plan, we are looking for input to direct us of the language we should use. For example, right now we're thinking safe and confidential. But again, need some feedback if safe and confidential actually lends itself to their concerns, because that is a concern that we've heard and looking to address it. But again, for now, as always, any person can come regardless of their legal status. But if you have some suggestions, I'd love to hear it as when we get to pulling that piece together, or anybody out there.
Hi. One of the biggest trends in child welfare that we're seeing right now is in regards to trauma-informed practices. And I think we're making some really exciting shifts in the way that we're treating the families that we see within that program. And I wonder, as we're talking about the older adults or the senior population today, how have you seen that coming into the work that you're doing? And or do you have hopes to start implementing some of those trauma-informed practices?
Yes. So MindSprings does provide trauma-informed care, and I think there's two different things. There's trauma-informed care, which is really the awareness of the prevalence of trauma and making that awareness a part of all the decisions that we make related to space, what the environment looks like, how we interact with one another, all of those decisions. And I actually sit on our trauma-informed care agency-wide team. So that is something that we have certainly embraced on many levels of the agency. But there's also the evidence-based trauma services. And those we also provide quite a bit of. We just sent quite a few staff from Aspen and Garfield County to it's called TREM, T-R-E-M, and don't ask me what it stands for because I don't remember. But it's a group treatment for people with trauma, adults with trauma. I do have staff who are trained in cognitive processing therapy, which is a lot like trauma-focused CBT in the child world. We have people trained in EMDR. So there's quite a few specialized services as well.
Do you have any hopes for child-parent psychotherapy?
Is this a specific model, you mean?
It is, yeah, for primarily used with survivors of domestic violence and their children. So it's like a co-parenting technique.
Possibly. There are a couple. I know Megan and I, and maybe this is the one, it's just not registering for me, have talked about another family-oriented, trauma-informed practice. It's hard. Sometimes we have to make decisions, much like Nan was saying. You'd like to be able to provide every single evidence-based service out there, and sometimes we have to make decisions because each one costs time and money and fidelity. And so I think we have to look at that. So I'm always open to looking at other models. Does our community need this? Would this be an effective use of our training dollars, which are very small? As we were talking about Medicaid, there are some things that, and that being one, that is hard to pull down with your Medicaid dollars. So we're open to anything that would benefit the community, but that one is not actually on like a to-do list right this moment.
With regard to children, our eligibility are extremely broad. And we have a program, it's, I don't know, $300,000 or $400,000 a year in funding that's called Family Support Services. And we have, if a child is in an environment that has caused a failure to thrive, and the situations you're talking about would make them eligible under that, we can actually provide funding to the family with state funds that don't carry a lot of restrictions for, we pay for tons of family counseling for families. And again, you know, our population is a small subset, but when we get to young children, it's pretty broad, and our early intervention case managers can, you know, put people in touch with supports that could help. And you know, in the cases that you're talking about, the supports are very different from our traditional population, but we do fund a lot of specialized services for families. We have paid for more dad counseling over the years than you can imagine, and it's paid off.
Hey, would you like to ask the final one or two questions?
No, everybody asked all my questions.
Oh, thank you. Okay, anyone else? One final? Going once? Twice? Okay, well, on behalf of the planning team, just want to thank all four of you for an excellent time today. Thank you so much.